Hi everyone, thanks very much for attending this pain lecture. So great to see so many people who've turned up on their evening. Now this is going to be, this is quite a detailed talk, so we're going to take our time through it, ask as many questions as you want. I don't want to rush through it in this next hour. So if this becomes 2 sessions, so be it, that's absolutely fine. This is one of those crucial parts of your junior doctor years and your med student years that we really examinable and really practical and useful, and you'll get so much benefit and lots of happy patients when you cure them of their discomfort and their pain. And most importantly, I want to introduce Joel Lott. So he's one of our registrars, and he very kindly, he's been doing a lot of pain rounds, so he's at the forefront when us consultants just get to sit back and kind of consult and answer questions. So Joel has done a great job being one of our pain registrars for many weeks. And so, yeah, he's going to be presenting this in coordination with me. And like always, feel free to ask as many questions, ask it in the chat. I'll be there to type out most stuff. And if there's something we both can't answer, we'll either refer to each other or get back to you with stuff. All yours, Joel.
Thank you very much. So, yeah, I'll get started. And fortunately, the first slide is a little bit about me. So we'll make this very brief. I'm a fifth year doctor. It's my first year as an anaesthesia trainee in Melbourne. I know many people who've signed up are from overseas. This is my dog. That's me in COVID. I do enjoy answering pain questions, and do not serve me any meals with coriander, please. Lahiru, do you want to talk very quickly about?
Pretty much. There's podcasts, there's YouTube channel, there's lots of resources. I've got a med students online course which you can access through the website on Thinkific. Just have a search around for that. And next slide. On all the usual stuff, we're on there as well. So you'll know if I'm advertising something, especially on the Facebook page and group and Instagram. Next.
So these are our rules and our basic assumptions for this tube, because we want you all to feel really comfortable and really comfortable getting involved and asking questions. You can unmute yourself at any point in time, and if we hear someone squeaking out, we'll stop talking and listen. Or you can ask in the chat, and Lahiru, do you mind just monitoring the chat just to see if there's any questions popping up in there that we can answer? We'll be asking people questions as well. It's a bit hard for me to see everyone who's in here, so again, I might be delegating Lahiru to choose someone to answer questions, and if it's you, just have a go. If you get it wrong, then you'll remember it better next time, and if you get it right, then that's great. But we're just all here to learn together. So you're all capable, intelligent, and you want to do your best to become excellent doctors. There's no question. So let's do it all together, and get it right, get it wrong, get it right. No one cares. We'll all learn, and you guys will pass your exams. We'll be trying to give you as much structure as possible to think through how you assess and manage pain, as well as categorization and some tables of data, because all of this helps to solidify things in your mind. And if you've got a structure to hang things off your pain assessments, then you can always sound more capable and like you're on top of things in front of your colleagues and your bosses and your patients when you present stuff. So let's get into it. Easy question to start. What is pain? And look, Shelley, you've already spoken, and I can see you at the top there. I'm going to pick on you. Can you give me a definition of pain?
I can give you a definition. I guess most importantly, pain is a subjective experience that the patient has, which is usually an unpleasant sensation in relation to a stimulus.
That's right. That's almost entirely the definition that the International Association has. Shelley, loaded question, does there have to be a noxious stimulus for a patient to experience pain?
Good. Yeah, that is a very loaded question. I would say probably no, there does not, because people do get things like phantom pain. And yeah, I guess rather than a noxious stimulus, pain is an unpleasant experience with a protective mechanism, I think.
Yeah.
I guess
That's great. That's really good. I'll just show you here. This is the International Association for the Study of Pain's definition, which they only revised very recently. So pain is an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. So it's an incredibly broad definition, and it certainly makes it easy to diagnose a lot of different pain in a lot of different situations, but also makes it hard to treat in some situations as well, because sometimes we don't have, a cut or a bruise or a scrape that we can treat. So that's great. As you said, that should say subjective experience, not objective experience. It is a personal and it is a subjective experience. A person's reported pain experience needs to be respected, as you said. And as you also said, we do not need what we call nociception, which is usually induced by tissue damage or damage to nociceptive neurons to have pain. And typical things that would cause nociception, things like a surgical incision or an infection in the tissue that it's infected in. When there's inflammation, you might have nociceptive neurons firing off, and that causes pain, but that's not required for pain. And finally, really importantly, a person's pain experience is influenced by their biopsychosocial factors, and that can include all of these things listed here. And it's often a dynamic thing that people learn throughout their lives, what is pain and how they respond to pain, and that influences their pain experience.
And just a quick thing with that. So often in your exams, they love definitions. Like this is like the level 1 stuff that is actually quite complicated. So if there's anything you wanted to memorize right away, it's that definition, especially on your anesthetic rounds or your pain ward rounds. I guarantee you that your consultant or your registrar will ask you what the definitions is. So to get on a really good footing, memorize that definition, because it just has a lot to do with how we approach it.
Does anyone have any questions about this slide? All righty, moving on. So I'm just going to give a few little like one-line examples, and I'd just like someone to tell me whether this represents an experience of pain or not. Lahiru, are you able to call out some names?
Hey, Taryn, what do you reckon? Is this pain?
Yes, I think it is pain. There's no nociception there, but as we said, it may be more psychological, emotional pain.
Absolutely.
That's right. Yeah.
And I've got this thing where, I remember the last time I was at the dentist and they had to drill some bone off my wisdom, as my wisdom teeth were impacted. It was completely numb, but just the force of it and the anxiety that I felt having that, like it just felt painful, even though there wasn't. I had to really just logically rationalize it. And I think we can all experience these things when we flinch or we really feel something, even though nothing has actually happened. So just to remember this point, because it's such a big deal in kind of the pain environment and the way we manage it is both biopsycho and social.
That's right. All right. The patient reports sharp, well-localized pain as you insert the cannula.
Yep. So that's probably obvious nociception. Let's go to the next one.
Several days later, the cannula site becomes red, tender, and warm to touch. The patient reports this throbs with dull pain, and the infection prolongs their hospital stay. And
Nikki L, what do you reckon that's about?
Yeah, that's probably some inflammation. So that's some tissue damage, which would be causing pain.
Mm-hmm. Absolutely.
Right. I agree entirely. And there are some definitions of pain and hyperalgesia and allodynia and things like that, which we won't touch on today. But this, if you're wondering, is an example of primary hyperalgesia.
Actually, why don't you go through that, Joel? Actually, Nikki, do you know what that is, primary hyperalgesia or allodynia?
I think hyperalgesia is when a typical, or how do you say it, a sensation or stimuli that normally causes pain is perceived as greater than it normally would be. That's
fantastic. That's really great. So it's a normally painful stimulus is more painful than it would normally be. Hyperalgesia. And allodynia, you're on a roll here.
Allodynia is when a stimuli that doesn't normally cause pain causes pain.
Yeah, fantastic. And you can often, we've all experienced that, like a bruise. If you touch the bruise, that's just touching, right? That shouldn't cause pain, suddenly causes pain. Same thing with the bruise. If you actually put a pinprick on that bruise, that'd be far more painful than a pinprick somewhere else. That is that hyperalgesia and sensitization that's occurring.
That's right. And in this patient could very well have allodynia as well. If you've got a site that's infected, you just touch that red sore skin, and it's when normally it wouldn't be. All right, and then several months later, the patient continues to report pain over this site with tingling and numbness, and the cannula has been removed.
Jessica Burden, what do you reckon that is?
Yeah, I would believe that is pain, because what was the definition again?
You go back to it if you like.
Yeah, no, I've got it here. Whilst there's whilst he's got actual tissue damage, he's also got some sensory and emotional attachment to that area and of what's occurred. So the pain is continuing for him.
That's right. And Jessica, do you know how long after an injury you have to have pain before it's called chronic pain?
This is where I get my months mixed up. It's either 1 or 3, isn't it?
Yeah, it's 3. Nice.
Okay.
Yeah, good job. So if this was 3 months later, the cannula has been removed, it's all healed up, and it's still sore, then we would call that chronic pain. And that's a entirely different entity again to acute pain.
There's another aspect to this, and this is one of those patterns you'll notice. What does tingling and numbness tell you about this pain, Jessica?
To me, it actually sounds like there's been some physical damage to some nerves.
Yeah, and what would you call that then? Nerve something.
Is it nerve palsy?
Oh, it can be a palsy, but yeah, neuropathic pain.
Oh,
and you said it right. So
yeah.
These are just the terms, and a lot of that Joel's highlight that chronic and acute is certain types of pain, and then neuropathic or somatic pain or visceral pain, like the type of structure that's damaged, and then you can kind of go into the other things as cancer and non-cancer pain. But that's great. So this is the stuff that you might want to observe and note, because it's really a big deal for anaesthetists and pain specialists.
And neuropathic pain, chronic pain often has a neuropathic component, but there's not complete overlap in those two Venn diagrams. Neuropathic pain results when there's injury or lesion to a nerve or part of the nervous system, which is causing the pain. And that's often why you get these strange sensory symptoms, and often why it can lead to chronic pain, because that nerve may never go back to normal. All right, any other questions about this slide before we move on? All right. So let's talk about how to actually assess patients in pain when we meet them at work, or on pain rounds when you're a student. Can anyone tell me very basically, what's the first thing you do when you want to take a history, or when you want there you go, giving it away, when you want to ask someone about their symptom? What do you do? And why don't we go with who's Nikki L?
I've already asked Nikki L. How about Samir?
So for a patient in pain, you want to take a full history and just work out, like, where's the pain? Did they recently have surgery, something like that?
Yeah.
And there's, I guess, assess how the pain's affecting them and if it's limiting their function.
Yep. And Samir, when you take histories, do you tend to use a structure, or how do you work through your history taking?
So for pain specifically, I use Socrates, so site, onset, character, radiation, severity, associated features.
Yeah, so that's the acronym that I learned when I was in medical school, and I think it works well. I'm not sure if everyone here will have used Socrates. Do you tend to start with open questions or closed questions when you do your history?
Open questions first.
Yeah, that's great. Yeah, exactly. So so much of your pain assessment can be gathered from just history taking without examination, without investigations. And so that's why if you are ever assessing a patient in pain, it's so vital that you take a thorough history. As you said, open-ended questions to start your questioning of the patient is really helpful, because if you just say to someone, tell me about your pain, the amount of information you'll get from that and the amount of information they'll give you that you might have otherwise missed with direct questioning can be quite significant. Because everyone may have learned a slightly different structure in their medical school, and I didn't want to shove Socrates down people's throats, we tried to come up with a structure that's easy to remember for taking a history. And Lahiru, how do you want to go? How do you want to go through it? Do you want me to...
Yeah, just go through it. I mean, when we were talking about this, like when I learned lot radio FM or something, some mnemonic like that. And over time, I've come to this conclusion where if something makes sense, I don't use a mnemonic specific, like a lettered mnemonic or acronym. I just think about it and make a structure to it. And so this really, Joel came up with this one after I told him about just, think about what the pain is and all the facets of it. Literally who, what, when, where, why, how is just such a great structure for asking the pain questions. And we'll go through, Joel, go through just the absolute significance of not missing a single point on this.
All right. So the first thing is who. So who are you speaking to? What's significant about them? Are they young? Are they old? Do they live with their family? Do they work? Are they unemployed? Are they disabled? Do they have a family? Do they have any mental health issues? It's all of it will have an effect on their pain outcomes. And some of those things are indeed risk factors for developing chronic pain. So if you just work through the W's, you'll get it all. What? So there's a lot in this category, and it's probably the most dense and the hardest to remember. But if you remember to assess the severity of the pain within your what, then you'll go a long way to getting a very thorough pain history. I've added some words here, some phrases here that you can use with what in it to sort of remember. To characterize the pain, is it dull, sharp, achy, throbbing? Any associated symptoms? What else have you noticed? And then any aggravating or relieving factors? What makes it better or worse? When? So this is all time-related things. So how long has it been there for? Does it come and go? Is it periodical? Is it colicky pain or is it constant pain? Is it constantly getting worse? Or is it constantly getting better? That will give you a heap of clues once you get familiar with different pathologies as to what is actually causing this patient's pain. Where? So where is it? And where does it go, if anywhere? The one other thing that I would probably add here is migration as well, location, radiation, and migration. Let's see, can you tell me? Chelsea Lou, do you know if someone comes in with midline or general epigastric tenderness in their abdomen and that migrates to their right lower quadrant, what is that? What sort of what are you thinking if that happens?
I guess the first thing that came to my mind would be appendicitis, but it kind of goes the other way.
That's great. Actually, no, you're completely right. Trust your gut. So yeah, appendicitis can start out very general, and then when that inflammation makes it to the peritoneum or the abdominal wall, then it can become very localized and sore there. So that's great. Yeah. So that's a situation where migration would tell you heaps about what might be causing the patient's pain. And then how. So I know we've skipped why, and we'll get to it later. So there's 4 W's and 1 H, which is a little bit annoying for those of us who are a bit OCD, but yeah, function. So how does it affect your patient? Because at the end of the day, they're the one dealing with the pain, and it may affect their life in a variety of ways. Lahiru, anything to add?
Yeah, that's good. And we actually might just skip forward through the next one. Just wanted to really put the point through. And in this particular basic surgical training exam, people didn't ask the onset. And so this was the the situation was actually a slow-growing tumor. So duration 1 to 2 months, and just slow rate of rise of their pain. And because of that, like half the people were mistaking it for subarachnoid, and the other half were getting it correct. So yeah, just a really important thing to have those down pat, have your mnemonic, have your memory aids for doing that. But that was really great from you guys.
Yeah, well done, guys.
Keep going.
All rightio. And then, yeah, just a didactic slide. So this is the W, this is the Y. What you guys have just done is the Y. So if you work through those other 5 dot points, the who, what, when, where, how, then as you gain experience, you're far more likely to diagnose the why accurately. And why doesn't always matter when we're treating pain. Sometimes the patient's in pain, it doesn't matter why, and you just give them pain relief medications and make it a bit better for a while. But knowing why can also be key to treating it. It'll also enable you to tailor your management plan to the patient in front of you. As with the subarachnoid hemorrhage, you can address acute and potentially life-threatening pathology. You can avoid prescribing medications which may cause more harm than good, and you'll certainly build trust and rapport with your patients because they'll know that you have taken a diligent and thorough history and that you care about their pain and what's causing it. All right, any questions from the crowd about that slide or anything we've talked about so far? All right, next slide. So I highlighted severity in that initial sort of structure. Alex Dawson, how do you like to assess severity for pain?
I guess the sort of starting thing is a sort of 0 to 10 scale, and see where they put it on there.
Yep.
But then the other good way to sort of see is how it actually has been impacting their life as well. So if someone's got hip pain, like they've had a fall and have hip pain and can't get up now because of the pain, like that's saying a lot about the severity of the pain as well.
That's right. That's great. Yeah, absolutely. Was there anything else you were about to say? Did I cut you off?
No, that's pretty much it.
Okay, those are really, really good. And pain scores, do you use them for everyone? Do they have any limitations?
I usually use it for everyone. I haven't really come across a situation where I haven't been able to use it that well. I guess except for peds.
What do you use for peds?
Yeah, I guess it's more just to do with like the behavior of the child. So, whether or not they're crying, whether or not they can be distracted from the pain and things like that.
Mm-hmm. And have you used any like visual tools or anything in your peds rotations for assessing pain?
I know they exist, but I haven't actually used them.
Yeah. Okay, no problem. That's excellent. So yeah, pain scores. I do the pain rounds at Western Health, and I ask every patient what their pain score is. And I don't. It's discrete, so it's a discrete number between 1 and 10. You say if it's 6 today and it was 3 yesterday, then it's gotten worse, and vice versa. It's only useful in the same patient though, so it's relative to that patient, and it's certainly subjective. And I would never compare pain scores between patients, but I would certainly use it to assess pain over time in the same patient. And it's really helpful to assess response to medications or activity or mood or anything like that. So that's great, yeah. I said it's highly variable between individuals, so 6 out of 10 is not the same for everyone. And there's people who you will give, you'll be almost knocking them unconscious with analgesia and they'll still be reporting high pain scores. There's some people who will always report high pain scores. It doesn't mean they're not in a lot of pain, it just means that it's very difficult to manage. And so there are other options, and you already discussed one of them. So these are the Wong-Baker faces, which many of you may have heard about in your pediatric rotations. So this is a tool for use in any children aged 3 or older. And the tool is to be used by the kids, not by doctors looking at the kids. So you give it to the kid and you ask them, to please, say, where are you on this scale? Yeah. And then you can go really basic. So you can just ask, is it mild, moderate, or severe pain? If they're struggling, or is it better or worse than yesterday? You can even ask. You don't have to give it a number, or small, medium, large. You can go really, really basic if you like. All right. Any questions about that? yeah, pain scores have their limitations, but I still use them every day. As long as you're aware of the limitations, it's still a good thing to do. All right, after severity, what do you assess next?
I think Alex mentioned that, the kind of the functional state of the patient, which is
that's right.
Absolutely.
That's right, you did, Alex. That's perfect. And there you go. There's some old people functioning. Do you have any what do you think? Should we pick on Alex a bit more, Lahiru, because he was on such a roll? Or should we pick someone else?
Yeah, go for it, Alex. What do you reckon? How do you categorize function? And we want a very specific way of doing it, because that way you can, again, really communicate this aspect to your bosses.
And you already started to do it with one of the examples that you gave.
Okay. I guess to start with, you sort of have to have an idea of what their baseline level of function is, so you can actually see how that's changed.
Mm-hmm.
And what else? How would you categorize them?
And that's all right, because we're kind of, there's kind of a nuanced point. So we're happy you said function.
Yeah, that's excellent, actually. All right, so let's I'll step you guys through the slides and how we've decided to classify them. So first of all, there's essential functions, and there's functions that if you can't do them day to day, then you're not going to get better and you're going to get more unwell. So let's go through. It's if you can't sleep, if you can't eat, if you can't mobilize, and if you can't take a deep breath and have a cough, then your pain is likely to be something that results in either prolonging your hospital stay or making you more unwell. And it's pretty obvious why those different things would. Deep breathing and coughing might be a little bit less obvious. So it simply means that you get sort of basal collapse and atelectasis, if any of you heard that term, in your lungs, and you're much more likely to get lung infections when in hospital, and you can't clear your secretions if you can't cough. So people have uncontrolled pain that prevents them from doing those two things, a significantly higher risk for respiratory complications. This is what you talked about, Alex, so site of injury function. So where did they hurt themselves, and can they move it to an extent that we would expect in this stage of their recovery? So if you've had a shoulder replacement, can you reach above your head? Can you rotate it? Can you hang out the washing if that's something that you like to do beforehand? If you're a labourer, can you work in the same way that you normally would? This obviously doesn't apply before some injuries are fixed. So if you have a hip fracture, then we wouldn't be looking at this as a score necessarily before your surgery, but after your surgery, we certainly would. And then anything specifically important to your patient. So this is, it's impossible to give all the possible examples, but different people have different things which are important to them. And simply being able to get to a kid's sports game without significant pain might be something really important for someone, and someone else might be an athlete, and they really need high function to be able to do what they want to do. And then this is a score that we use, the functional activity score, to assess function at the site of injury, and we usually use it post-operatively. So we've got essential functions, we've got site of injury functions, and we've got important to the patient functions. And then to assign a grade to these functions, particularly the site of injury function, we can use this functional activity score, and it's very simple: A, B, or C. No limitation, mild limitation, or severe limitation. And if someone's in the C, then they likely require some kind of alteration to their analgesic regimen. Otherwise, they're not going to improve.
And just to give everything the significance of this, so you're on your pain round, you ask every single patient their pain score, then you check every one of their functions. So you're asking all those questions, and then you document it, and then you give like a functional activity score. That would be very impressive to your supervisor if you can do that. Absolutely. And then the relevance of this then is that once you can do essential function, that really is one of the biggest markers for can you go home, like for example, after day surgery, or if you're after a stay overnight. If you can do those things yourself, you get to go home as part of your criteria, providing a few other things are all right. But if you can't, then you kind of have to stay in hospital and get those sorted. So that's the kind of stuff. Your pain score, ask those questions, report a functional activity score. So pain 6 on 6 on 10 goes to 8 on 10 with deep breathing cough or with movement, and then check what those function is, then report functional activity score B. And then the next part of this is that, someone who's got just always high pain scores, the best thing you can do, you give whatever medication, they've got chronic pain, they're always at a functional activity score of B. They're always at a severity score of 7 out of 10. The best you can tell the patient is, can we get you functionally better? And then suddenly you're moving across A, B, C, rather than the pain severity numbers. And that's what a really big use of it as well with chronic pain.
That's right. That's absolutely right. And often you can find yourself chasing pain scores when the patient is actually quite functional. That's a time when, if you chase pain scores with ever increasing doses of analgesic agents, then you may end up getting to a point where you're causing harm with your medications more than you're helping the patient, because you're not actually improving their function because it's already pretty good. And you're also not improving their pain score because they've got very difficult to control subjective pain. Actually,
there's an interesting thing with PCAs, or with just any general opioid medication or strong pain relief, people always titrate themselves down to about 3 out of 10. They never really try to get down to 0 out of 10. So that's just an interesting point. Once you get to 3 out of 10, you're pretty much most of the time happy with your patient's severity score.
That's right. That's a really, really good point, actually. A very good point. Yeah. Okay. So you've assessed, you've done a full history of your patient, you've assessed the severity of their pain, and you've also assessed the level of function. The final thing that you might look at about a patient to see how bad their pain is, particularly if they can't speak to you, and that could be because they're kids, because they have some cognitive inability, or maybe they're even unconscious. Are there any clinical features of pain? Obviously, a very leading question in the title. Who haven't I asked? Matthew Nagel, what do you think?
In terms of clinical features of pain, so I guess when on sort of general inspection as well, when you sort of first sort of observe someone sort of who's clearly in pain, obviously you can tell from their sort of facial expressions. They sort of writhing in pain? Can they sort of not move or walk or anything like that? The way that they hold their arm, if there's particular points that they're sort of in pain, I guess. There, in terms of localizing, you want to be able to have a look at, so obviously is it actual penetrating injury or anything like that that's directly causing the pain, or are there any sort of, if there are features of chronic pain, there are certain features you might be able to tell by sort of certain skin changes or hyperalgesia as well. Other certain neuropathic signs, I guess, in terms of that sort of a clinical assessment beyond a history.
That is all very correct. That is so that's a lot of stuff that you do. So you pretty much described an examination, right? So so you do your general inspection, then you look at the patient, maybe you look at their wound, you look for rebound tenderness with their abdomen, you look for all this different stuff. What about really objective features that you're not asking the patient about, but you might sort of clinical signs rather than symptoms?
Clinical signs. In terms of sort of for pain,
what do you reckon when you're in pain? Do you reckon your heart rate goes up or down?
Yeah. So there'll be your heart rate does go up. Yeah. So there might be breathing a little bit more hard, a little bit more sympathetically active, I guess. Yeah.
Yeah, that's right. And there's many reasons why a patient might be tachycardic or hypertensive or be, as you say, breathing rapidly. But one of those reasons might be pain. And so we call these relatively objective measures. People who are particularly anxious can also show a lot of these features. But yeah, so the three main vital signs that I would look at would be their heart rate, their respiratory rate, and their blood pressure. sort of on the other side of that, sometimes if people, particularly young people, are in a lot of pain, they can have excessive vagal tone and significant parasympathetic drive, and that can cause bradycardia. And in bad situations, hypotension. I've never seen hypotension secondary to pain, but I have seen certainly bradycardia secondary to pain. And in a really serious setting where people aren't able to ventilate properly because they're so sore with their breathing, then they might become hypoxemic. And people can also sweat and become quite pale. These top 3 vital signs for a bit of an anaesthesia spin, these are the 3 vital signs that we would look at on a patient that's anaesthetized to tell if they are experiencing nociception. So they're anaesthetized, so they're unconscious, so they can't be having the sensory or emotional experience of pain, so they are not in pain, but they can still be nociception. And for those patients, that nociception still leads to increased sympathetic drive, as you mentioned, and they can become tachycardic and hypertensive. And so for those patients, we would treat their nociception or their pain under anaesthetic with analgesic medications. So I really liked the way you stepped through that examination description, and it makes me think that we should have had a slide about it. But yeah, these are also some objective measures that you can look at your patients. Lahiru, did you have anything to add?
All good.
Okay. Now, some of the people who, when you entered what you wanted to get out of the session, some people mentioned that the pain pathways were a bit confusing. So we'll touch on them. They are, I'm not sure how deeply they'll be examined in medical school examinations, but we'll just go briefly through pathways. So it's at its most basic, Morgan M. Do you know how pain is? So say I get a little cut on my index finger. How do I know that I'm in pain?
Because it's kind of an advanced question, I might just throw it to anyone. Does anyone know the pain pathways?
I can give it a shot. So there's like the localized like peripheral nerves surrounding the tissue that's been damaged in the scenario, that then have their action potentials and conduct to the spinal cord, which then has those nerves up to the brain. I can't remember which part of the brain.
That's okay. That's okay. Do you know what part of the spinal cord by any chance?
The dorsal.
Yeah, beautiful. The dorsal horn. Yeah, nice one. Yeah, and then it all goes to the brain. So you've described exactly what we call the ascending pathway. So it goes from anywhere in your body up the spinal cord to your brain, and the sort of final location where you'll interpret that pain is in your somatosensory cortex. So that sort of homunculus that they put over your brain in all those silly looking pictures with the different parts of your cortex which tell you where you're feeling pain. That's where the signal will ultimately go and what will generate your perception of pain. So as you said, and just down the side here, there's this big old arrow with these drug classes in the box. Those are the drugs that can work at that level to reduce your sensation of pain. This should not be examinable material. I do not think it will be. It's far too advanced. So as you said, yeah, you've got your peripheral nociceptors that are responding to trauma. You've got a peripheral nerve, which is heading to your spinal cord. At the dorsal horn, and I will note that this dot here that's going to the dorsal horn should really be going here. Can you guys see my cursor? Yeah, so it should be going here. This is the dorsal horn, not out here. And then one of the main tracks, the one that takes sort of cold sensation, but also sharp, well-localized pain, is the spinothalamic tract. And that goes to, as the name says, from the spine to your thalamus. And from your thalamus, it's distributed to your somatosensory cortex. So yeah, excellent. And now if we have an ascending pathway, we must have a descending pathway. Morgan, do you know anything about the descending pathway?
I don't think so, sorry. I'm assuming it goes down the ventral horn.
That is a really, really good. That is a really good one. I actually need to look that up. I need to look that up.
Oh,
where specifically it goes. No, that's. Thank you very much for pointing out a hole in my study. So the descending pathway, it is mostly a way to modulate, and as I say here, descending modulation. It modulates the ascending pathway. So it can either hit the accelerator or push the brake on your ascending pain traffic. So it's, and the centers in the brain from which the descending pathways start are very diffuse and non-specific. So you don't need to remember any of them. These are the two key neurotransmitters involved in descending modulation. And this is the reason why some medications that inhibit noradrenaline reuptake or serotonin reuptake, like antidepressants, can reduce pain because they're activating this descending pathway. Pain matrix, very non-specific areas in the brain. It's all coordinated in the brain stem. It has its effect at the dorsal horn, which is the same place that all those motor neurons, all those sensory neurons from the periphery synapse. And in the shortest sentence possible, it engages processes which inhibit the ascending pathway. That's if it's working in a way that we want. It is also possible for descending modulation to activate ascending pathway, or as I said, press the accelerator down and make your ascending pain traffic worse. But in health or in therapy that we do, we're trying to inhibit the ascending pathway. Lahiru, anything to add, or does anyone have any questions about this quite busy slide?
And what I love about this is that it is kind of, I guess, more advanced topic, but I just feel like it's just so useful for me to remember how I can utilize multimodal analgesia. As you can see, there's not that many pathways. It'll be pretty impressive to learn that, and I'm not sure if it is examinable, but who cares? This is really great learning and really great to understand the pain pathways anyway. But yeah, does anyone have any questions about that?
As you can see along the right-hand side, like so many of the drugs that we use have effects at many different levels of this pathway. So, but some don't have total crossover, which is why multimodal analgesia, one of the reasons why multimodal analgesia can be such a good thing, is because you're not only inhibiting or activating different receptors, but you're also hitting different parts of the pain pathway to reduce people's sensation of pain. Alrighty-o. So, this is the meat and potatoes, and we've only got 10 minutes to go, Lahiru.
And this is okay. So what I think we might do, I think the best part about this is going to be, I'm going to get you, Joel, just to go through it at your own pace. Yep. I'm going to start and then just go through the slides. So I think what we can do is we're going to keep going with this lecture to get you all the information stuff. And then the next session, we're going to put far more clinical vignettes and just kind of ask people, how would you manage this? And I'll try to give as much kind of, pain specialist anesthetic information to make this lecture series like seriously practical. So this will be the baseline lecture, and then we'll go into that stuff into the next thing. So go for it, Joel. Let's crack on.
Sounds good. All right. So we'll have a crack at trying to categorize the ways that we intervene to help people's pain. Is it Asare?
Actually, Joel, I'll get you to just teach this stuff.
Just go through didactically?
Yeah, exactly.
Okay. Yeah, cool. No problem. All right. So I'm going to categorize it for you. So we can be very invasive, or we can be non-invasive. So things that are invasive are things like surgery or regional techniques. And when I refer to regional techniques, I mean sticking needles in different places to usually inject local anesthetic and potentially an opioid around a nerve that provides pain relief to the field which that nerve supplies. So that can be epidurals, it can be spinals, it can be fascia iliaca blocks in the hip for fractured hips. There's a lot of different regional techniques at our disposal. And then non-invasive options. So if we've got non-pharmacological, we've probably got pharmacological coming up as well. So there's it's important that when you're looking at your patients who are in pain to think not just, oh, what drugs am I going to give them? But also if you say to your boss, look, well, I want to think about pharmacological and non-pharmacological ways to treat this pain, then they'll be impressed immediately. And it will also help you to think about what you can do for them more than just give them some more endone, which will help you feel a little bit like you're having a little bit more actual effect on helping their pain process as well. So physiotherapy and occupational therapy are your friends in hospital, and they do a lot of that assessment of function that we spoke about earlier, and they're the ones who say this patient's not functioning well enough, potentially because they're in pain, so we need to optimize some stuff before they go home. Distraction, very good with kids, as many of us will have seen in our pediatrics rotations. Immobilization, so it's true for most fractures. Keep it still and it won't hurt as much because the periosteum, where the most nociceptors are, is not rubbing on itself or nearby tissues. And slings, rest, ice, you've got a sprain or a strain, and then pharmacological. So we can give tablets or syrups or whatever. We can give parenteral, which means sort of around enteral, so not enteral, not going through your digestive tract, analgesics, and that can be infusions or patient-controlled analgesia buttons. It can be boluses that we give ourselves, and this is the main kind of analgesia that we give in theatre in anaesthetics, because the patients are asleep, they can't swallow tablets. And topical, like any local anaesthetic under the skin or even on the skin. Some of you might have seen MLAR cream, sometimes called angel cream, which is a gel that you put onto the skin, often with kids before you put a cannula in, which makes skin go numb. All right, so this is the question that all of us have had at some point in our life, and hopefully as years go by, we have to mull over this question less and we know a bit more about what we're dealing with. So, if anyone asks you...
Actually, we should ask this one.
Should I ask? Okay,
yeah.
Cool. All right. Okay, sorry, you're back up. What do you know about, I've already put it up there, so the cat's out of the bag, but what do you know about the World Health Organization analgesic ladder?
Hello. Not too much. I think it's probably like goes like simple analgesia, like maybe NSAIDs and like paracetamol, then sort of escalates up to opioids or something like that. But I'm not too familiar with it.
No, perfect. That's pretty much exactly right. So you start with non-opioids, as you said, like paracetamol and non-steroidals, plus minus adjuvants, which is sort of a growing field of all these medications that aren't Panadol, they aren't non-steroidals, they aren't opioids, and so we call them adjuvants, but they have a variety of mechanisms of action. And then we move through weak opioids and strong opioids, plus minus more adjuvants. So that's it. You pretty much go from non-opioids to opioids, and make sure that you don't skip a rung on the ladder, because then you can be progressing to a medication which may have stronger analgesic potency, but may also have a broader side effect profile that you don't want to expose your patient to unless you absolutely have to. And if you can achieve good analgesia with paracetamol and some non-steroidals, then that's what you should do. And this all is, when we talk about multimodal analgesia, if you follow these steps, then you'll make sure you're providing multimodal analgesia to your patient, which when you call the pain team for help and they say, what have you done so far? You can say, I've done all this. And they say, all right, you've definitely done all that you can do. It's time for us to come and help.
And Jonathan, what is the importance of multimodal analgesia, do you reckon?
It's allowing you to target each of those different points, whether it's the local site or at the spinal cord or centrally, as well as perhaps even, I'm not sure if adjuvants include things like SSRIs or something, if that's going to like impact your sort of emotional response to pain.
And what's the advantage of it then?
I guess you may be able, if by attacking it at multiple points, you might be able to use less of potentially each of them or less of the serious ones.
Absolutely. So you hit on 2 points. you get more efficacy because you're attacking all the different receptors, so hopefully it works better, and you're using less of each, so now the side effects of any one drug is decreased. So really two massive effects of this multimodal analgesia concept.
Yeah, that's perfect. Yeah, and if you'll certainly find if you try to use just one analgesic agent to get on top of someone's pain, then you often will rapidly approach the point where you're getting side effects appearing that are more significant or more annoying than the pain itself. All right, so shall we talk about the first step on the analgesic ladder, which is paracetamol?
And I'll get you to run through all of these. So yeah, run through all of these, because then in the next session, we'll have this lecture up, which everyone can have a look at, and then we'll give some clinical vignettes. So yeah, thanks for that.
Okay, sounds good. All right, so paracetamol, here it is. Apologies for the huge table with only one row in it. So as far as our WHO ladder goes, this is a weak non-opioid, paracetamol. I've tried to include mechanisms of action for you for all of these medications. Unfortunately, paracetamol has a relatively obscure mechanism of action, and there are multiple proposed mechanisms, some of which are relatively definite and some of which are not, but thought to be the case. So I've written them all here, and I've tried to highlight or bold the important words. So prostaglandins we'll touch on when we get to non-steroidals as well. Cannabinoid receptors and cannabidiol and CBD oil has a growing use in cancer pain. NMDA and substance P. So substance P is part of the inflammatory soup that develops around like a cut when you get it in your periphery, and is a neurotransmitter that usually transmits pain signals. And NMDA is the same, and some of you may have heard of ketamine, which is a NMDA antagonist as well. And then an indirect serotonergic effect, we already spoke about serotonin as a part of the descending modulation pathway, and then reduced sensitivity of bradykinin receptors. Bradykinin is also a inflammatory mediator that is produced by damaged tissues. This is very helpful. Dose. So if you start anyone in hospital on Panadol, I would start 99% of people on 1 gram oral Panadol. You can write QID or Q6 hourly. It's the same thing. QID means 4 times a day. Q6 hourly ends up being 4 times a day as well. And if you're looking after kids, then you give 15 milligrams per kilo. And so any kid over 65 kilos, there's probably more and more of them these days, you dose them as an adult and you stop at 1 gram. The main caution with Panadol is hepatic dysfunction. So if someone has hepatic dysfunction, then I would consider not prescribing it at all, or simply dose reducing to maybe TDS. So 3 times a day, Q8 hourly, or even twice a day. And you need to monitor their liver function if you're going to give Panadol to someone who already has liver dysfunction. In the very, very elderly, or in people who are very, very low weight, then I would also consider dose reducing. So when I say very elderly, I mean like over 90 years old. Or if they're a very cachectic, little frail, very low weight little old lady, then I would consider dose reducing, and maybe even dosing per the pediatric guidelines for that as well. So 15 milligrams per kilo, because there are adults who are less than 65 kilos. The main adverse effect of Panadol is liver toxicity, particularly an overdose. And all of you in some point in your medical career will see someone who has intentionally overdosed on Panadol in an attempt, in sort of self-harm attempt. The hepatotoxicity mechanism we won't go into here, but it develops very slowly, and it requires infusions in hospital, and it's very unfun. So that's Panadol in a nutshell.
And what I love about this is that, so Joel's really just synthesized it, essentially, when you look at whatever, MIMS or any other kind of Australian medicine handbook, you just get a whole bunch of stuff that is like either not very specific, like, it's always contraindicated with allergies, or GI upsets, diarrhea, vomiting, that's always common. Rashes are common. But really, the point of difference of Panadol is hepatic dysfunction. So if you were to remember anything, all the usual stuff's easy to remember because it's common to everything, but hepatic dysfunction is what you want to really focus on. Hence, for all of the other ones, we're really going to go to the point of difference of the side effects or the cautions, rather than talk about all the multiple things that could possibly ever happen.
Yeah, that's right. Yeah. So if you don't see me right, allergy to this medication is a caution, then it's assumed. Just pretend it's there. I promise. All right. Anyone have any questions about paracetamol before I move on?
Actually, there's a good question there. What is the degree of hepatic dysfunction we are worried about? Do we look at deranged LFTs? So, yep, as a junior doctor, if you saw some level of dysfunction, you just want to flag and go, look, there's a bit of liver dysfunction. To be honest, the liver has so much capacity that there's kind of this rule that your GGT, ALT, and all your aminases may be inflamed, but your synthetic function and ability to metabolize is almost always still preserved. So as an advanced thing, as long as your INR, so your clotting and your albumin levels are good, chances are your liver is still able to metabolize stuff. That's just a rough go. If you saw some crazy deranged LFTs like in pancreatitis or fulminant hepatic failure, then all bets are off. You really want to be cautious. If you have a liver transplant, definitely you got to be cautious. If you have liver resections, you would decrease dose. But for most just minor elevations or whatever of your transaminase and GGT, it's really not usually a problem. That's my practical advice for that. So, we often look at INR and coags and albumin. That's a far bigger indicator of problems with liver. Or if they've got signs of, fulminant liver failure, and these signs will be, jaundice, having ascites, encephalopathy, and maybe, elevated bilirubins and things. Yeah. Yeah.
All the things that are included in your child Pew score.
Here's another one. Around what weight would you start thinking about reducing paracetamol doses? I saw an anaesthetist reduce the dose of Panadol for a 50-kilo young healthy woman. Is this something we should do? Yeah, there's probably not that much evidence for a lot of this. So, once you get to 50 kilos, as long as they've got an adult liver, they're probably okay. The toxic dose is in the 8 to 15 grams. So you're probably still safe to give a few doses of a full dose. But, I think you'd be very safe to reduce it for a 50-kilo person. I don't know if there's any good evidence for that, but it's a reasonable thing to do.
Yeah. Yeah. And I think the guidelines in ED, it's like if someone comes in and they've had less than 10 grams in 24 hours, then you don't have to do any specific treatment for paracetamol overdose. So that's clearly significantly above this amount, which is only 4 grams in a day. All right, on to the next one. If I can use the computer. Yeah. All right, non-steroidals. So a broader class than Panadol because it's more than just one drug. We tend to divide non-steroidal anti-inflammatory drugs into those that are selective for the COX-2 enzyme and those that are non-selective. But the non-selective ones all have variable degrees of affinity for the different COX enzymes. So cyclooxygenase 1 and 2 are enzymes that are, so COX-1 is expressed constitutively throughout your entire body, and COX-2 is only expressed in response to inflammation or tissue damage. And that's why we talk about, that's why people initially tried to make COX-2 specific inhibitors, because the feeling was that if you could make only COX-2 inhibitors, it would inhibit the inflammatory response to pain or to tissue damage, without having all these other negative side effects of non-steroidal anti-inflammatory drugs. The reason they have all these side effects is because COX-1 and 2 mediate the production of prostaglandins, which are an incredibly important autocrine and paracrine hormones throughout the body. They're expressed in, as I said, most tissues, in platelets, in your liver, in kidneys, everywhere. So I've given you a little mechanism here. I've made a note of saying this is inducible COX-2 inhibition because COX-2 is expressed in an inducible manner. And you've got doses here, which these are doses that I would give to patients who are healthy with no comorbidities. And if they had any of these issues, one column to the right, then I would consider not giving them at all or dose reducing. Particularly celecoxib, 200 milligrams twice a day is the maximum dose. And you often see it as 100 milligrams daily or 100 milligrams twice daily to reduce the risk of side effects.
You go, Joel.
Oh, I was going to talk about the cautions now. So did you want to say something about the dose?
No, you're good. Go for it.
So as you can see, there's heaps of risk factors. And I realized that I've made a little acronym. You could remember BRAG, bleeding, renal, asthma, gastritis. That's unintentional, but BRAG, and then there's cardiac risk on top of that. BRAG-R. These are the things we worry about mostly for people who are having non-steroidals. So as we already said, allergy or some kind of reaction in the past, then you worry about that too. But the cyclooxygenase enzymes also mediate the production of thromboxane A2, which helps platelet aggregation. It's in platelets, it's expressed. So your risk of bleeding is higher because you don't clot as well. Prostaglandins have a complex interplay with the afferent and efferent arterioles in the kidney, and so you can get renal dysfunction, and you should also dose reduce or avoid in renal disease. The cyclooxygenase pathway has a common origin with the lipooxygenase pathway, and so if you block COX, you increase the activity of lipooxygenase, which shunts that whole pathway towards creating leukotrienes, which is what is made by LOX. And leukotrienes can cause bronchospasm and bronchoconstriction. So we often ask people when we're planning to give them a non-steroidal in theatre, we say, if they have asthma, we say, and how do you go when you have Nurofen? Do you have any problems? And that can give us an idea if they have non-steroidal sensitive asthma. Prostaglandins are important in several mechanisms of gastric protection. So they reduce acid secretion, they increase mucus secretion, they increase bicarb secretion as well. And so you can cause gastritis, gastric ulcers with non-steroidals. And they do increase your atherothrombotic risk as well, which doesn't really seem like it makes much sense when you also increase your bleeding risk, but it has been borne out in clinical trials that people on non-steroidals, particularly with a history of AMI and stroke, are at an increased risk of AMI and stroke. In the elderly, you can dose reduce or avoid, and always remember that people who are older are often on many medications. And many of you may have heard of the triple whammy, which is a non-steroidal, a diuretic, and either an angiotensin converting enzyme inhibitor or an angiotensin receptor blocker. Those three drugs together are highly likely to cause renal dysfunction because of the interplay between the different drugs. So caution there. And then the COX-2 inhibitors, it's all the same risks as the non-selective, except again, clinical trials have borne out that you probably have a reduced risk of gastritis and bleeding. So if someone has none of these other risk factors, but they really get bad gourd or they've had a gastric ulcer in the past and you really want to give them a non-steroidal, you could consider a COX-2 inhibitor rather than a non-selective. But probably because there's more shunting towards the thromboxane A2 pathway by COX-2 inhibitors, there's an increased risk of AMI and stroke relative to the other non-steroidals, the non-selective steroidals. So there you go. But if you just remember those two boxes on the far right, when you're thinking about prescribing non-steroidals in the future, you'll avoid 99% of hairy situations. And avoid prescribing them in 99% of the people that shouldn't have them. Anything to add, Lahiru?
Yeah, I think that's such a good summary. Again, these are literally the questions I'd ask every patient before we give them non-steroidals. Any kidney problems, any asthma problems with non-steroidals and asthma. Often asthmatics are fine with it. Do you have gastritis or gourd? And what is this a bleeding risk type situation? So yeah, again, really, you want to be able to go through these questions quickly to then know you're pretty safe to prescribe this stuff to your patients.
Yeah.
There's a good question. This is a really important pharmacokinetic question. With dose reduction, can you still achieve the same analgesic effect because it is metabolized slower? So essentially, the dose reduction is a combination of this. It's just a smaller body mass for that drug to go into. Therefore, it's important to just lower that dose so you don't get an overdose of the medication. But also, there might be a reason to so it's mainly a body mass thing and a volume of distribution thing. If you're a smaller person, you don't want too much drug in the body. So that's why you dose reduce. That said, in a smaller person of a younger age, it might be metabolized slow as well. That there are exceptions to that. But some, in various age groups, you may have hypermetabolism. So dose reduction is more about the total body size of a person. And also, is it true that NSAIDs can worsen hypertension? Yeah, so that is true. I'm not sure the pharmacology has something to do with altering kidney function, isn't it?
It's right. Yeah, it's right. So prostaglandins have a kind of a yin and yang effect at the kidneys. So the macular denser in the kidneys can release prostaglandins, which stimulates renin release, which activates your RAS system, which will overall work to increase your sodium and water reabsorption and increase your blood pressure. But it also, the prostaglandins also have a direct vasodilatory effect in the kidneys, which will cause afferent arterial vasodilation, and that will actually increase your GFR and cause you to filter out more solute and more water. So it clearly has it's a contradictory effect. Prostaglandins have a contradictory effect at the kidneys, and the balance between those two effects is what determines the ultimate effect, not only of non-steroidals but of prostaglandins themselves. So, but yes, clinically, non-steroidals can worsen hypertension, and it's probably through activation of the renin-angiotensin-aldosterone system.
And just to give it perspective, it's not necessarily a reason that you'd stop using it. Often, like it may not have the biggest effects. So there's plenty of people who are on antihypertensives, and often you'll give them a course of non-steroidals post-operatively. That's just not a problem. So don't worry too much about that. But if you had a real hypertensive disorder, long-term use of non-steroidals would be something you'd have to really be cautious about.
Yeah.
There's another good question. If someone has been on regular non-opioids for a long time, do there tend to be any problems with suddenly ceasing them? I'd say that the easy answer is no. So if someone is on big dose opioids, you get this effect of physiological and psychological dependence. That definitely becomes a problem, and you have to wean off those drugs, opioids. But paracetamol, the situation you'll often see someone in is, say they've got chronic osteoarthritis or arthritis of some sort. They may be on really long doses of Panadol that are potentially dose reduced. There's just contention about how long you can be on non-steroidals and Panadol for regularly for these patients. But let's say then they get a knee replacement, and then in far less pain after the knee replacement is healed, you can pretty much stop the medications. And I don't think I haven't heard of any problems with that. If someone has heard of something with that, please let me know, but there shouldn't be a problem at all. There's no physiological dependence or psychological dependence to worry about.
Yeah, I agree. I haven't heard about that either. Hey, I'm going to add it to this slide. I'm really sorry that I forgot to put it there, but non-steroidals are absolutely contraindicated in pregnancy. And the reason that's the case is because they can cause, the prostaglandins are necessary for maintaining the ductus arteriosus in the fetus in its open state. And if you give non-steroidals, the lack of prostaglandin can cause that to close, which is vital for the circulation of the baby, and so it can cause premature intrauterine death. So I will add it to the slide, and I apologize that it's not there now.
And I've got another really good question here. I've seen the pain team prescribing non-steroidals with a PPI for a patient with a background of reflux. Is this something we can routinely do, or should this be left to the experts? Look, it's not so bad to do that, especially if you're in a situation where a person's young, fit and well, never had a problem with gastritis. Just a bit of a nuance here. Reflux is when the acid comes up the esophagus, and it may or may not be related to pain. Gastritis is when you've got decreased mucus in the stomach. That's when it can cause pain in the stomach lining. And then heartburn is when there's reflux going up the esophagus, causing that heartburn feeling in the esophagus. So there's a few different pathologies there, but let's say the non-steroidals cause some kind of gastritis or heartburn. If I really need, I'd generally stop the non-steroidals. But if they really, really need to be on it, you'd say to your supervisor that I think they need it for multiple analgesia. The pain is far more problematic. Let's try with a PPI and see how it goes. Most young, fit patients who don't have any problem with it, you don't really need to start them together. You can just start non-steroidals and be at that. There is a thing in ICU that if people are in ICU with a lot of kind of stress and a lot of opioids and things, you will start them on a PPI just as a matter of course as well. Yep. Hope I answer your question.
And those people in ICU, they will start them on a non-steroidal even on a PPI even without being on a non-steroidal because the risk is so high. Mm-hmm. I would encourage you, if you are going to prescribe non-steroidals, to try and have an end date or a weaning plan, or not necessarily a weaning plan, but an end date. So this for 2 weeks or 1 week or a month, but people should not be on long-term non-steroidal anti-inflammatory drugs because the risk of any of these side effects, particularly gastritis and renal disease, increase over time with cumulative dose. So it's not worth keeping them on it long term. And if they need something long term, then you need to think about what else you can give. All right, happy to move to the next one, Lahiru.
Yeah, go for it.
All right, weak opioids. We've given you 2 options here. So the first one is tramadol, and tramadol is in the past has been labelled a dirty drug by some people, and that's because of the third column, which is its mechanism of action. So it does 3 different things, all of which are probably good for pain. So it's a weak agonist at the mu opioid receptor, which is where sort of all traditional opioids act. It also stimulates both release of and inhibits reuptake of serotonin. And it also is a noradrenaline reuptake inhibitor. So 2 pathways that are involved in descending modulation, as is opioid receptors are also involved in descending modulation. And they're all combined in the one drug. So that can be good because it's kind of a one-stop shop for your pain relief for many people. And the weak mu opioid receptor agonism effect means that a lot of those side effects that are really common with opioids, and we'll touch on these later, you're less likely to get, and the addictive profile is significantly lower with tramadol as well. So those are some suggested doses. It's also an IV medication, which can be really helpful if someone's normally on tramadol and they come in and they're nil by mouth, or I don't know, they got kicked in the face by a horse and so they can't swallow a tablet. They can have IV tramadol. The cautions are largely related to the fact, as you said, it's this dirty drug, particularly people who are on antidepressants such as SSRIs and SNRIs, so selective serotonin reuptake inhibitors or serotonin noradrenaline reuptake inhibitors. Tricyclic antidepressants and monoamine oxidase inhibitors are all but things of the past now, and you're unlikely to see them in clinical practice. But SSRIs and SNRIs are common, and the risk is that if you stimulate too much release of and inhibit too much reuptake of serotonin, then you can develop serotonin syndrome, which I can go into if you like. It's a syndrome that's characterized by like fever, hyperexcitability in your muscles, so you get clonus, you can get reduced conscious state, and it's quite a morbid condition that needs to be treated urgently. So it's definitely something to avoid if possible. And then there's also a seizure and epilepsy risk, which is probably due to messing with all these different neurotransmitters at once. And then codeine, which is often combined with paracetamol into Panadine, which a lot of patients will come in and tell you that they're on. It's a prodrug, so codeine has no analgesic effect, but it's hepatically metabolized, so in the liver, to morphine, which is kind of your quintessential opioid. That's the dose, 30 to 60 milligrams orally every 6 hours as an 60 milligrams QID as a max, and 60 milligrams is what's in what you'll have in. So Panadine Forte will be 500 milligrams of paracetamol and 30 milligrams of codeine. So they'll have 2 of those tablets, so a gram of paracetamol, 60 milligrams of codeine, and they'll have it every 6 hours. And people who like codeine swear by codeine. The problem with codeine, or the cautions, is that it's got very highly variable metabolism, and this is all due to genetic polymorphism with the CYP450 enzymes in the liver. And so you can have people that metabolize codeine incredibly quickly. They're called ultra-fast metabolizers, and so they get a rapid morphine hit to their system, which can have, as you get such a high peak dose or peak plasma concentration, that's a really dangerous time for opioid side effects. And then you can get really poor metabolizers that you're giving codeine to, and they're getting no morphine release really at all. And so it's not a good analgesic for them. You can see here that there's a decent amount of variation across the continents as to who is poor or ultra-fast metabolizers. And so these are some just reference numbers. 9% of Caucasians and 30% of Southeast Asians are poor metabolizers, but people from Africa will have different metabolism profiles. People from the Americas will have, well, South America will have different metabolism profiles, and it's unpredictable. It's completely unpredictable. So people, very multicultural word these days. You've just got no way of knowing if someone's going to be a slow or a fast metabolizer until you give them the drug, or unless you do CYP450 genetic testing with them before you give them the drug, which would be very expensive, I imagine. So the risk with codeine is that you have morphine toxicity in fast metabolizers. Anything to add to this slide, Lahiru?
No, that's really good. And not to say that you guys shouldn't be prescribing codeine. Like it's really common for non-anesthetic people to do it. It's just a common, easy to use drug. I mean, it just has a lot of problems from our point of view. So we just, we just avoid, because we're just so used to giving endone. If we need, our rule in anesthetics, if you think of giving codeine, you just give paracetamol separately and you give some endone, and just keep it simple like that. But that said, hey, do what your bosses do, because that's probably part of their tradition as well. I've got a bit of a rule for prescribing tramadol, which might be useful. So most young fit people get 100 milligrams oral IV, QID PRN. But as soon as I get to an older or smaller person, so the smaller they get, the older they get, I tend towards 50 milligrams oral IV TDS, up until a point after about maybe 70 years of age. I think a lot of us are a bit cautious about giving tramadol to elderly people, though.
Yeah, I will add that to the slides as well, actually. So tramadol has a higher risk of developing sort of delirious or confusion type side effects in the elderly. So I will add that.
There is a good question: when to prescribe tramadol immediate release versus sustained release? Yeah, I mean, sustained release, generally speaking, it's going to be if you're doing some kind of BD dosing and you expect the patient to be kind of post-operative or having pain that's going to last for a bit of time. It makes sense to give something at sustained release, sure. But generally speaking, I've used other medications for that, with tramadol as a regular dosing, either PRN or regular, but having 6-hourly options for it. Yeah, I've just generally always just prescribed it in immediate release, because I've had another pattern of prescribing other long-acting stuff. And is drowsiness another side effect of tramadol? Look, it's just a really unlikely side effect in most people. You might get it as a slight risk in the pediatric population, but in adults, it's just not one of those things that we think about. It doesn't cause respiratory depression or drowsiness to anywhere near what opioids will do. Another good question: at what level of drowsiness or AMS, acute mental state or altered mental state, do you call it an adverse drug reaction and alter management? Been seeing a few people with codeine allergy documented because it made them confused last time they had it. Yeah, I mean, so that's a really good question. If something is the expected action of a drug, you give fentanyl and they become apneic, or a potent opioid and they become apneic, or they have respiratory depression. Yeah, that's not a side effect. That's a side effect. That's just the expected reaction to that agent. So in the codeine situation, that could be just one of those things with a fast metabolizer or some other thing, maybe even the paracetamol, I don't know. But if it caused confusion, confusion is such a non-specific symptom of many, many different things that, first of all, I don't know if I'd put it down to the drug, but the fact that it's a codeine allergy doesn't faze me. I just don't use codeine in that situation because I'll just use a better drug like oxycodone.
Yeah, and often those kind of like very vague descriptions of what the allergy was, it's a patient-driven addition to the ADR list, and it's because they didn't like how they felt when they had the drug, and that's completely fine, and you should give the patient that drug. And yeah, confusion is so nebulous, but yeah, I'll just avoid codeine. There was one more thing I was going to say. And then the SR versus immediate release. So often you'll see people prescribed as an overall sort of comment about sustained release versus immediate release medications, in particular opioids. So overall, the trend towards prescribing sustained release opioids is decreasing, except probably in the acute post-operative period, at least in hospital medicine. In the community, there is still a significant amount of sustained release opioids being prescribed. And in that context, especially if they're given for a long period of time, there is an increased risk of addiction, psychological and physiological dependence. In a hospital setting, and particularly a post-op setting, if someone's had a big surgery, you know they're going to be sore every day for the next 5 days. And as Lahiru said, it's very reasonable to start them on a sustained release medication, which provides a foundation of analgesia. But it's also highly likely that when they're doing some of those functional tasks that we discussed before, like engaging with physiotherapy or OT, or when they're even sometimes when they're trying to get to sleep, pain sort of becomes more obvious when you're trying to get to sleep, that they'll need something extra on top of that. And that's why you chart some sustained release, and then you also chart some immediate release with a cap on how much they can have every day. And so they can have that on top. So Tramadol IR versus SR, I think, yeah, you could even chart both. If you don't have another sustained release opioid there, you could give both. But usually, as Lahiru said, I would use a different opioid as my long acting, and then tapentadol as the breakthrough, plus the other opioid that I was using as a breakthrough immediate release as well. Okay, next slide, unless anyone has any more questions. All right. Strong opioids. Busy table again. So you'll prescribe these regularly in hospital. We've got 3 different drugs in different forms listed down the side. So oxycodone, morphine, and tapentadol are the 3 drugs that we've chosen, but there are certainly many more strong opioids available. I've also endeavored to write the brand name, because they often go by different brand names. And so oxycodone and morphine are just pure opioid agonists. They're very clean in that sense, in that they only affect one pain pathway, but they affect it at all the levels, so brain, spinal cord, and your peripheries, as we showed in the previous slides. There are doses here for you to use, but they are merely guidelines, and you could very easily see a 90-year-old lady on 5 milligrams twice a day of sustained release oxycodone, and that would be no problem, and that would probably be sufficient for her. Tapentadol has the added effect that it is similar to tramadol. It's also a noradrenaline reuptake inhibitor, but it's a stronger mu-opioid agonist, and it's a weaker serotonin reuptake inhibitor. So you hardly even, in clinical practice, you don't really consider the serotonin effects at all. And you can certainly prescribe it alongside an SSRI. But yeah, it's got a stronger mu-opioid effect, and still the noradrenergic effects, which can be good for descending modulation. And these doses of tapentadol that I've put on this slide are exactly equivalent with the oxycodone doses on this slide. So 5 to 10 of oxy is equivalent to 25 to 50 of tapentadol. according to Faculty of Pain Medicine opioid calculator, which I'd encourage, once you start working clinically, I'd encourage you all to download the opioid calculator from the app shop, and you can always tell what equivalent dose you're giving, whichever opioids you're giving. Now, the cautions, the potential adverse effects for all opioids are listed in the far right-hand column. And I've split them into sort of the common ones that will bother you on a day-to-day basis, probably as a junior doctor, and that you can treat relatively easily. The more serious ones, which hopefully you shouldn't see too much, and then the really long-term ones, which you need specialist help with. From a cautions point of view, you really need to be careful when giving morphine to people who have renal impairment, because morphine is broken down or metabolized in the liver into 2 metabolites. And one of those metabolites is incredibly potent as an opioid, which is M6G or morphine 6-glucuronide, and M3G, morphine 3-glucuronide, can actually have an anti-analgesic effect. So it can cause increased pain in people. So if you give morphine to someone with really significant renal impairment, they may end up having severe side effects because of the incredibly potent M6G. And that's someone that may end up becoming sedated or having respiratory depression because they weren't able to clear that highly potent metabolite. I've just written down the bottom here, Targin also contains naloxone. And that's the only drug here that has a different medication included with it, and you'll prescribe it very commonly. Naloxone is an opioid antagonist, so it works against the oxycodone really, but the prevailing opinion is that the naloxone remains in the gut, and there's mu opioid receptors in your gut. So it's an opioid antagonist in the gut. It prevents your gut hypomobility and constipation. So that is the reason that they made Targin. I think the evidence is kind of sparse on whether it actually does prevent constipation.
Oh yeah, so I saw some evidence where it is probably about as good as Cloxol and Senna. So regular laxatives is about as good. That's
pretty good.
The interesting thing, so yeah, naloxone, right? It is highly metabolized by the liver. So as soon as it gets absorbed by the portal system, goes past the liver, it just gets deactivated completely. So just imagine then where you've got someone with liver failure and you give them Targin. If the naloxone bypasses the liver, then it will have an antidote effect on your OxyContin. So you'd have to be just really cautious with that kind of stuff as well.
That's right. Yeah. So like, for example, at Peter MacCallum, the palliative care team does not like you giving Targin to any patient with any hepatic dysfunction, because they're concerned about in the naloxone making it to the systemic circulation and causing the oxycodone portion to not work. If you're a cynic, then also Targin, if people crush it up and inject it, then they get a dose of intravenous naloxone, which is not what they're after. So from that point of view, it's kind of a safer drug to have on the streets as well. Anything else you'd like to talk about this slide, Lahiru?
It's all good.
Okay, so then the only thing left to talk about is some of the newish adjuvants that are around, and here is 3. So pregabalin and gabapentin are anti-neuropathic agents mostly, and that's where the evidence for their efficacy is. They have a complex mechanism which I won't get into, but essentially they inhibit pain signal transmission in the spinal cord. And these are safe starting doses that I've written for you here. The reason, unless the patient has renal impairment, in which case I would dose reduce, and you can start as low as, if you've got a very frail old person, you could start pregabalin as low as 25 milligrams at night and see how they go. Because the far right column shows you the side effects, which are sedation, dizziness, and visual disturbance. The first 2 are the most concerning, and people can get quite sedated and unsteady on their feet with these medications, which is why we give it at night in the first instance and why we assess the response and don't just go to 75 milligrams BD immediately, because there's every chance that they'll have it in the morning and then they'll have a fractured hip by the evening. And because they also produce a bit of sedation, they actually can be quite good medications for pain which is preventing sleep. Other medications that could be included in this list that I haven't put here is things like amitriptyline or nortriptyline, which they're tricyclic agents and affect that descending modulation pathway. And then clonidine is a drug that has a lot of different effects. So it's an analgesic medication, it's an anxiolytic, so an anti-anxiety medication, and it's also an anti-hypertensive. It's strange to say that an alpha-2 agonist causes hypotension, but the reason is that its peripheral effect is transient, and so it causes peripheral vasoconstriction very briefly before it has these overwhelming central effects, which are via the noradrenaline pathway, the descending noradrenaline pathways, to cause analgesia, to cause sedation, and to reduce your sympathetic outflow, so they reduce your blood pressure. This is a very safe dose, 25 to 50 micrograms orally TDS PRN. PRN meaning pro renata, which means as needed. And I always write for all patients that I prescribe clonidine for, do not give this drug if their systolic blood pressure is less than 110 millimeters of mercury, because it almost inevitably will cause a small drop in your blood pressure, and you don't want to give it when their systolic is 100, because then very soon it will be 90, and then you'll have to go and review them. They might feel unwell.
And it's one of those drugs that does a bit of everything. So imagine the times I'd use it, a patient who's hypertensive because of pain and is a bit anxious. This is kind of like the drug that deals with all of those aspects of that patient. So
that's right.
It's not as convincing when you give it, like it's not as convincing of saving someone's severe pain with opioids or ketamine, but it's just one of those kind of reasonably efficacious things that you just have to add after you've tried everything else.
Yeah.
I've just got another really good question here. Is magnesium also used as an adjuvant? So I saw it on a chart on the Anaesthesia chart and don't know why. So yeah, absolutely. So NMDA, the NMDA receptor, which ketamine acts on in a very efficacious way as a non-competitive agonist, magnesium also blocks that same spot. And so it has a weaker kind of effect as an NMDA antagonist. So you'll see it used. Would I say it's just another thing to add if you've got a really complex pain patient? But I wouldn't say I use it commonly. It's just often for likely to be very painful cases on patients who might have pain syndromes, really.
Yeah. And I think, it's one of quite a few drugs on the NMDA receptor. That's a really good question. I will add it to this table. I'll add amitriptyline, nortriptyline, and magnesium to this table.
Beautiful. Hey, is that
that's the lot. So the next slide is talking about adverse effects of opioids.
We're gonna leave that for now. And look, so apologies. Obviously, we wanted to get through a certain aspect of it, and obviously run a bit longer than we meant to. But hopefully, you guys got a lot out of it. Might skip. What I might do is share the screen. Share my own screen actually.
I'll stop sharing. Oh, no,
you can see that QR code. Joel, so essentially give a little summary of what we've done. If everyone can just take their phones out and give some feedback on what you might like to see out of this session, or any improvements for next time, please do so. That'd be really useful for us. And most importantly, in the next lecture, which we'll go through, we're going to go through all the really practical stuff. Now that you have this lecture to really solidify your knowledge about the doses and the multimodal protocol, we'll try to make it even more practical by giving lots of case scenarios that you'll just find all, so common on the wards, and a few nuanced ones. Again, I never want to just dumb it down for medical students, because you'll be interns and doctors soon, and you might as well see all the situations that occur as a doctor, which we can highlight to you, because we've done pain for many years. Joel, do you want to just give a quick summary? I'll let you go back to you sharing.
Yep, I'll just there's a question as well from Saleha as well. So is alfentanil used regularly in practice? In anaesthesia, it's used very regularly. So alfentanil is a very short-acting opioid that is from the fentanyl class of opioids. It's not used in a ward setting because the effect is too transient to be useful in a ward setting, and also it's it's the dose that it's given in, it's likely to cause apnea and sometimes even hypotension or cardiovascular depression. So for that reason, we use it in theatre usually during induction, which is when we're putting the patient off to sleep, because we want a drug that works very quickly and causes analgesia very quickly, but then can wear off not too long after, and we can give other long-acting opioids while they're asleep. Anything to add to that, Lahiru?
That's all really good. We'll have some we'll have some kind of medication lectures as well. We'll go through the details of all the crazy opioids that we use. But yeah, alfentanil, that's exactly right. Really fast acting, theoretically the fastest onset opioid, lasts about 10 minutes at the 10 to 20 mics per kilo dose.
Yeah.
And when will the next session be? We'll be using the same link. That's a really good question. So I'll discuss with Joel. I'll send an email to this group, but also put it on ABC's of Anaesthesia Facebook page and group. And I'll probably put another link to it and another event so that you guys can sign up to. So yeah, I'll make sure I communicate that sometime this week.
All right, so let's just go through very quickly as a summary what we've spoken about. So, that's back to me. So we talked about what pain is. We've talked that it's a subjective experience, not an objective experience, and then it's both sensory and emotional, and it does not require tissue damage to have occurred for a patient to feel pain. And it's influenced by multiple factors that are intrinsic to the patient. We've gone through some things that are pain, and then we've gone through our structure with our 4 W's and 1 H question: who, what, when, and where, and how, to make sure that we take a thorough history and then we're able to diagnose relatively accurately why the patient is in pain and choose an appropriate analgesic for them. We assess severity with pain scores, faces, as well as we function with our functional activity scores, both essential site of injury functions and important to patient functions. And then we've also looked at objective measures of pain, such as vital signs and sweating and pallor. We briefly touched on the ascending and descending pain pathways and the different medications that work at different levels there. I think the most important things to remember is, remember dorsal horn. And then if you remember the word spinothalamic tract, you remember that it goes from the spine to the thalamus and then to your homunculus and your somatosensory cortex. And descending is very nebulous, but probably emerging importance in pain management, and particularly chronic pain management. We talked about invasive and non-invasive means of providing analgesia, and always remember that your non-pharmacological means are available to you to utilize on the ward. And we've talked about multimodal analgesia by utilizing the WHO analgesic ladder, always starting with non-opioids and working our way up to make sure that we're providing our patient with the most optimal analgesic regimen. And then we talked through Panadol with its unclear mechanism of action and our concern in hepatic dysfunction, our non-steroidals and our diverse list of cautions, all related to prostaglandins. We talked about tramadol and codeine and the fact that tramadol is a drug that works on multiple receptors, which is a good thing, but also a bad thing when we're combining it with other drugs which act on those same same neurotransmitters. And codeine is a prodrug, so we need to be careful to make sure that whoever we're giving it to is actually getting the appropriate dose of morphine, which is what it's metabolized to. And then oxycodone, morphine, tapentadol, all strong opioids, all very reasonable to use at the doses written here. If you're not sure, then start low and go slow. We will discuss these common opioid side effects down the right next time and how to manage them. And we've talked about our adjuvants, and this table will be larger the next time you see it.
Beautiful. That's great, guys. So yeah, we'll sign off now. So that's the end of the lecture. But yeah, I'll stay around with Joel for another few minutes. So if you have any questions, please please just shout out or write in the chat. But thanks very much for listening in and watching. And we'll definitely send you the details of the next pain lecture very soon.
Thanks everyone for coming.
I had a question actually.
Go for it.
I was just wondering, a large part of what you were talking about with pain seemed to be very much about the experience and like these conscious experiences.
Mm-hmm.
I'd heard about these ideas of like, subconscious pain or whatever, and even if you were using like some sort of regional block for a knee replacement, that you could use opioids, long-acting opioids, even though the patient may not feel it, the pain, but and then that can have outcomes. Or there were some ideas about like subconscious pain. I was wondering, is this all kind of hand wavy, or is this influence your practice?
I've never heard of the term subconscious pain, so that might be a new thing. If you're talking about, so did you mention amputation, Jonathan?
Oh, just like a total knee replacement using some sort of regional block, such that you would not expect the patient to really be feeling a pain, but then to still at the same time concurrently use opioids.
Oh, okay, got it. So that's really rare. So if we do a spinal anesthetic for a hip or knee replacement, or a regional anesthetic for any other operation, for the actual operation, we'd just not use opioids intravenously. We would, however, put opioids into the spinal, but that's just to make the local anesthetic just work better and have less block regression. That said, once the spinal is wearing off, so say the spinal lasts 3, 4, maybe up to 6 hours sometimes, you'd start loading opioids as the local anesthetic wears off. But there would be very little reason to put opioids while the regional anesthetic or spinal anesthetic is working.
Yeah, and if we go back to this slide on the pathways, the beauty of regional blocks is that you can stop the pain signal either in the peripheral portion or in the peripheral nerve. So at the nociceptor, like the peripheral nociceptor or the nerve. And if you've completely ablated that response or that sensation of pain, that nociception, then you may still get trauma and inflammation at the site, but all of these central processes which sense pain and then sometimes sensitize you to pain down the track are sort of cut off. So yeah, I think I completely agree. Like when I see it in clinical practice, it's as the spinal's wearing off that you might start to use opioids. But we did discuss sort of like if you're under anesthetic, you could have something that might be called subconscious pain, which is nociception without consciousness. And certainly people have a sympathetic response to that, and in that case we would definitely give opioids. Yeah.
I have a question on a similar vein. I was just thinking about the indications for using local anesthetic intraoperatively once the patient's already anesthetized. So is it, as you mentioned, to diminish the sympathetic response and the hemodynamic response to pain, or?
Yeah. Do you want to go, Lahiru, or I can have a go?
Yeah, so if you think of pain management as that whole, invasive and pharmacological, non-pharmacological technique, the first thing to know is there's no evidence for what mortality benefit of using local anesthetics or regional techniques. So that's not really a thing. So if I use a spinal anesthetic versus a general anesthetic, the only thing I do benefit from is a short-term pain post-operatively, but no better outcomes into longer term. So that's important to know. If I was to use, if I did have a very specific chronic pain patient with some kind of really weird pain syndrome or some other factor that contributes to the increased risk of post-operative pain, then I'll definitely opt for regional anesthesia in that specific population. The reasons for using local anesthetic are just to make pain. It's just another aspect of multimodal analgesia. If I've got a toe amputation, I can just use an ankle block, so blocking the nerves of the ankle. I don't need to give a general anesthetic, but that's really just another option that's based on the patient, their preference, and other factors. It's just another kind of quiver and another arrow in the quiver.
I've seen a surgeon give local anesthetic during an appendectomy.
Yep.
So my question is, what's the indication for that, given the patient not going to feel the pain?
Oh yeah, that's right. So you will stop. There's this, I mean, first of all, that local anesthetic will last beyond when the patient wakes up. So that's one important thing. There's also this thing called central sensitization. So if you do give local anesthetic early on when they're doing the cut, that means that, you know, as they're cutting, the tissue that has local anesthetic won't feel the pain. Therefore, it may have some benefit afterwards. That said, there is limited evidence, if no evidence, for putting local anesthetic before the cut or at the end of the cut. That's not necessarily a thing yet. But, you know, if it does, it could go either way. So a lot of surgeons will just do that. Sometimes surgeons will put local anesthetic with adrenaline, and mainly they'll use it for the vasoconstrictive effect of having adrenaline or inherent vasoconstrictive properties of the local anesthetic, which occurs with long-acting local anesthetics such as ropivacaine.
And you actually, so you might see the credit for this picture is from a paper called New Concepts in Acute Pain Therapy, Preemptive Analgesia. And preemptive analgesia is the idea that you can give someone some kind of medication before the insult, and the efficacy is increased by giving it beforehand rather than giving it afterwards. And I believe the only drug that actually has any effect for it that's proven at this stage is paracetamol, like oral paracetamol pre-op, plus minus regional. And then there's lots of things that you can give which have an analgesic effect that lasts once that analgesic is completely left the body. And ketamine is one of those medications, as well as non-steroidal anti-inflammatories.
I've got a different one there. So preventive analgesia with ketamine is definitely a thing. But
yes.
When I was studying this, preemptive analgesia was just debunked. It wasn't a thing.
Yeah, right. Well,
unless there's recent evidence, you'll
really
probably study it.
I've actually come across. This is getting way too
first part.
But it's an area of contention, and I've had different lecturers and different textbooks say different things, but they all come under this umbrella of protective analgesia, and then split into preemptive or preventative. And then, as you say, Lahiru, like preventative is you give medication and then it's worn off, the medication's gone from your body, but you're still having an analgesic effect. And yeah, so that's one of the things that ketamine does.
Great questions, guys. Any other questions? I think it's time to sign off. Thanks so much for joining us. We'll put this up on YouTube when I get time to edit it. And yeah, if anyone had any problem with their voice being heard and giving answers, let me know as soon as you can, so I don't put it in. Otherwise, thanks very much, and see you guys around.
Thanks, everyone.
Thank you so much.